are now live, Chair.
Good afternoon. Welcome to the Health Overview and Scrutiny Panel. I'm Councillor Ian Holder, Chair of the Health Overview and Scrutiny Panel. Members of the public are invited to view this meeting online, and those present are requested to keep their microphones on mute and only turn them on when you are called to speak. Members are requested to keep their camera turned on at all times. Officers and external presenters are requested to turn your cameras on only when you're presenting the reports and answering questions. If you'd like to speak, please write your name and RTS, request to speak in the chat function. And I'd now like to invite those present to introduce themselves. Got Councillor Heaney. Would you like to introduce yourself? Sorry, mid sip. Councillor Heaney.
Yes, I'm getting my microphone right. I'm just taking a cup of tea as well. Sorry about that.
No problem.
I'm Councillor Graham Heaney. I'm a Labour councillor representing St Jude Ward on Portsmouth City Council.
Thank you. Councillor Agate.
Good afternoon, Councillor Arthur Agate, representative from East Hants District Council.
Thank you. Councillor Briggs.
Good afternoon. Hampton County Council representing the Waterloo Ward and North Stakes.
Thank you. Councillor Pepper.
Councillor Martin Pepper representing Gosport Borough Council, Peel Common Ward.
Thank you. Councillor Rains.
Good afternoon, Councillor Rosie Rains, Hayling East, Havant Borough Council. Thank you.
Thank you. Councillor Burkett.
Good afternoon. Yes, Councillor Burkett from Fareham Borough Council, representing Fareham North West. I'm the deputy today. Councillor Miss Ball cannot attend.
Thank you. Councillor Atkins.
Yeah, Councillor Matt Atkins, Portsmouth City Council, I represent Cosham Ward.
Thank you. Welcome to the meeting. I've had apologies from Councillor Brian Madgwick and Councillor Joanne Bull. No one else at the moment. We've got a few missing, but hopefully they'll join soon. Declarations of members' interests. If any members have any interest to declare, please indicate and I'll call on you to declare your interests. Anyone? No? Okay. Next, item 3 on the agenda. Minutes of the previous meeting on 17th of March. Can I have a proposer and seconder for approval of the meetings? Minutes, sorry.
Happy to do that.
Thank you. And Councillor Briggs, are you happy to second?
Happy to second.
Thank you. So those minutes are approved. Thank you. So we can go on to the presentations. And the first presentation, I think, is from Southern Health NHS Foundation Trust. And Paula, would you like to give us an update on the report?
Yes, I will. Thank you so much. And thank you for the invitation to come back. Paula Hull, my colleague, the Director of Nursing, may well join us at some point. So I'm Paula Anderson. I'm Finance Director and Deputy Chief Executive at Southern. Clearly, you have the report in front of you. This is following, I think we were with you probably about 6 months ago. It might have been January. To take you through the initial recommendations and response from Southern. And this is an updated version of that report that shows the actions that have been taken since then. Obviously, I'm very happy to take questions. The other piece of work that we've been doing is we've been working with our Quality and Safety Committee within the Trust to develop the sort of outcome metrics that we would keep watching over a period of time. So this is, there's one-off responses in here that have changed processes, changed practice. And what we now want to see is if we look at particular metrics around how patients feel about a service they're getting from us, or our response to complaints, or how the investigations process works, for example, trying to make sure that we follow up and talk to patients, their families and carers to say, so how was that? Did we meet your requirements? So that over a period of time, we will continuously look at the things that we think are important, the spirit of this report from PASCO, that just make sure that we keep an eye on all of those things. So we're doing that, and we're setting ourselves sort of baselines for that and improvement targets where we require them. And clearly we're working with the CCG, who are providing oversight and assurance around the actions that we've taken. and we've provided evidence packs up to the CCG of our actions, and they will be going through them and making sure that they're comfortable, that they can see that we've done what we've said we've done, and that what we've done hits the brief. So that's a really helpful piece of work that they're doing with us. We're in the middle of it at the moment, so I can't sit here and say it's all done and sorted. They're reviewing our evidence pack. On the first 6 or 7 that they looked at, we were able to they were able to sign off the majority of them, and then there were a few things where they said, actually, we want to come and say spend the day with your complaints team, and once we've done that, then we will say that we've that the actions have been signed off. So some really good joint working there. In addition, the CCG is working with colleagues in other trusts to make sure that people are that other organisations are self-assessing against some of these really important recommendations, to check that as a whole people move forward with these areas, not just Southern Health. So I hope that's enough of an introduction. I'm really happy to take any questions, and if there's anything I can't answer, if it's detailed enough that I need to ask a colleague, then I'll clearly provide it to you tomorrow.
Thank you, Paula. Julie, I think I missed you in the declarations, didn't I? Oh, you're on mute.
Sorry. My name is Julie Richardson. I am the councillor for Hayling West for Havant Borough Council. Thank you, Paula. Could I just ask you, with your complaints, I'm very pleased to see such a rigorous complaint system being initiated. Can I just ask you what is in place for making sure that those timelines are kept to and that things are followed up, particularly at ward level?
Yes, thank you. Thank you very much for that. Yes, so there's quite a lot in place. Obviously, complaints will often come into a central repository. They might go via a particular team, but they'll often come in centrally. And we then have quite a lot of processes around making sure that the complaint is acknowledged in good time, and that we get the question or the thing that the person's concerned about out to the team, the operational team, to answer and understand exactly what's happening. We have processes in place to ensure that if we're not able to respond within a very quick time period, that there's visibility of that. So Paula Hull, for example, who's trying to get into the call at the moment, she will know if a complaint has come in, say 10 days ago, that we've not managed to answer. Now, sometimes complaints can be really complex and do require lots of different things to people to get involved and to be able to solve parts of it. And when that's the case, we'll often agree with a complainant that actually they do want us to take a bit longer to make sure that the answer is comprehensive and has covered all of the ground that it needs to. But in the main, we try and answer as quickly as we can. We think sometimes these things can be made more complex than they need to be. And actually getting the direct clinical teams involved as quickly as possible to have a conversation often will be able to cut through quite a lot of the issues, because you know the human involvement is so important. So and also I have to say our chief exec has absolute oversight. If things are going beyond 10 days, he you know, him and Paula talk about it, and he seeks to understand why there are delays. So yeah, we've got some quite strong processes around that, and hope to see that that's of a benefit to most people. As I say, there will always be the odd complaint that just takes longer to solve, but we'll do it slower with the complainant's permission.
Thank you very much for that. And Chair, can I just say I do have a declaration of interest around the orthopaedic department. Thank you.
Okay, thank you. Councillor Heaney, I think you had a question.
Yeah, thank you. Well, it's a couple of questions actually, if I may. One is, I was on the Health Oversight Committee, then I came off and I'll come back again. So I just wanted to clarify, is this report and recommendations dealing with some of the historic problems that Southern Health had? This is not a new set of issues that I've missed while I've been off. Is that correct?
Yes, so in the main, the report that was written was about was around patients' experiences that happened between 2012 and 2015.
Right.
And the spirit of the findings and the work that Mr. Pascoe did was not around clinical care that these patients or their families experienced. It was broadly around the things that happened after that. How well did we manage any complaints or investigations into what needed to have happened? And their findings were that some of those areas were where we had some inadequacy. So it does relate back to 2012-15, but it's just trying to make sure that this report's been written reasonably recently, has been based on some of the history, and was an attempt to demonstrate what has been done, but also to get to the gold standard, as he described it in his report, what more could be done. And we obviously had subject experts on the panel that supported with some of those questions. And that's partly why it's been important that other organisations have also been asked to look at the report and say, well, how well do we all think we're doing on these things? Is there room for improvement across all organisations, not just Southern Health? Because we're trying to get quite rightly a gold standard.
Okay, that's helpful. My two questions relate, one to process, and the second one is more an issue about how you monitor. The first question about process refers to page 10 of our report, recommendation 2. You talk about the policy being shared with a working in partnership committee on 17th of February and being approved by the Quality and Safety Committee on the 15th. I was thinking, if the is it the consultation with the working in partnership committee which happens after the thing's been agreed, or what? It seemed very confusing. I wasn't sure what the process was. Who's in charge of what? It looked a bit odd when I read it.
I suspect Paula's managed to join us. I wonder if it was QSC on the 15th of March. You might not remember, Paula.
It's February here in the report. Yeah, I
one of those dates is wrong. I completely agree.
Yes, the process is the working in partnership committee, and my apologies for being late. I've had difficulty joining the call. I'm Paula Hull. I'm the Director of Nursing and Allied Health Professions for Southern Health. The working in partnership committee is our committee which has membership from voluntary sector and local groups, carers and other members. So it's a very important group for us. The Quality and Safety Committee is a board subgroup and has our non-executive directors, our executive directors, and is a formal group that reports to the board. And I'll just check the dates for you in my calendar.
Thank you.
Okay, well, as I thought it looked like it might be the wrong way around, because it looked like the official committee was the quality one and the consultation has taken place after that. The other one I wanted to ask about was about how you monitor compliance, and it relates to recommendation 11, and it's on the other page, talking about understanding the triangle of care. And it says an introduction module to give all staff an understanding of the principles and processes available online. The principles are included in the local induction. And obviously, if you're inducted as a new member of staff, you do get it. But what about existing staff? Because if I know anything about training, and I know it happens in my workplace, when you're very busy, the last thing you do is probably go online and look at stuff which is about training, because there are so many other things to do in your day. So how do you ensure that if you're an existing member of staff, you have actually worked through that thing and the principle and process? Do you have to sort of sign it off, or how does it work?
Paula, are you able to come in on that one?
Sorry, I'm busy trying to find the dates in my calendar. Yes, so as you know, we have a range of turnover in terms of our workforce, and as you say, that can be quite complicated, chasing people around. So you're right, we do have to track individuals through their individual induction, preceptorship and ongoing training. We have something called an MLE system, which is a really great electronic system, which means that people, we can see what they're doing, so we know whether they've undertaken elements of training or whether they haven't, and we can also track an audit trail of whether they're compliant with that training or not.
Yeah. Okay.
Sorry,
and the other thing to say, I think, Paula, is that actually you know, people's working practices will be visible to others and seen. And obviously within the divisions and teams, we have people that are sort of championing for carers, or they are the sort of main carers links. And so if people are seeing that actually there's issues around the way that somebody's practicing and working on a daily basis in terms of their connections to carers, or if there's feedback that suggests that they're not working with carers in a thoughtful way, then that will be picked up by local management as well, and part of supervision or appraisal, or just day-to-day, you know, wouldn't it be better if type conversations. So I think we can hit it from both directions, can't we?
Okay, thank you. That's very helpful clarification.
Thank you. Councillor Agate.
Thank you, Chair. It's a good report, very comprehensive. One of the things I did appreciate was the fact that you're approaching customers, whatever you want to call them, with down the line with your workforce and everywhere else, with this request to help rather than interrogate. It's one of the things that's been coming up to us lately, this reaction with your customers to interrogation rather than let's help you and let's help us at the same time. Well, I thought this was an extremely good report. Thank you.
Thank you.
Thank you. Councillor Briggs.
Thank you. Well, I thought the report was good, but over the past 10, 11 years that I've been on the HASC, not the HOS, but the HASC, I've read so many of your reports. And a while ago you were good, and now you went back to requiring improvement. So what is going to be different this time, that with all what you've put in place is actually going to work? Because somewhere it keeps on going wrong, and I'm not meaning to be rude, but I do read the same thing more or less over the last 10, 11 years.
I think that's an absolute fair statement, and I think we're well aware in the NHS themes that we have across the country, actually, that we are focusing on very carefully, because they're themes that people keep telling us, and you're absolutely right that we need to be held responsible for making sure that we work through those. I think talking about our good rating with CQC and moving to requires improvement, there was a real acknowledgement, I think, through that report, that we'd been through the 2 years of the pandemic, which has unfortunately had quite a detrimental impact on some of the workforce. So some of the things that were moving forward quite well and the CQC reported on when we were rated good, some of that work had not progressed in the way that we had hoped it would. So I think that was one of the reasons, but not only that reason. I think the other thing is that we've learned a lot about how we manage learning and how we work together to improve. And I think we've learned a lot about that. I think in some cases, in the early days, people might put some guidance or a policy in place and feel that that was the action, as opposed to focusing on the outcome and being really clear about making sure that difference had occurred and working with people so that they understood. And there was a behaviour change and a change in the way they were thinking, not just a change in policy and process. And I think we've really understood that. And I believe that will be the thing that will make the difference to really sustaining these changes, when people truly acknowledge and believe, and there's a culture that people change their behaviour because they understand what has gone wrong and what they need to do to put it right.
Thank you. I just hope I don't have to read one again. I do realise you've had difficulties through COVID, but it wasn't good before COVID.
No.
And I'm never sure if it's because the staff, but you've put so much in for them, but particularly the families, so they're always kept well informed, and you do all you can for them because they just don't always seem to understand what you are trying to do. And apologise, Chairman, at the moment I can't get my hand down. Thank you.
Thank you.
Thanks. Just one question from me. You said there's a project underway to look at engagement with lesser heard carers, sort of minorities and rural areas. How's that going, and how long will that take, do you think?
It's a really interesting programme, and actually on Saturday we've got Mental Health Awareness Day in St Denis in Southampton with one of those projects, which is our BAME carers group in St Denis. And we've been astonished actually at the number of people that have come forward that want to be involved. It's going to be a really exciting and very community focused event. So we're really pleased with the engagement we've had with communities. It's not going to stop that work. It's going to continue. And we all know that the pandemic has increased visibility on some of the inequalities we've got with some of our areas of deprivation and some of our groups who don't get a voice. This group have really grabbed hold of this, and believe me, they've got a voice now.
Good. Was there any other questions? No. Thank you for coming, Paula and Paula, and I know you've got to shoot off, so thank you.
Thank you. Thanks very much for the support.
Thank you.
Thank you.
Next up, we've got item 5 on the agenda, Portsmouth Hospitals University Trust. I think Chris Evans, do you want to give us a quick update on the report?
No problem, and thank you for inviting me today. So I'm Chris Evans, Chief Operating Officer and Deputy Chief Exec over here at the QA. So this is an opportunity really to provide an update on the work carried out by the organisation, and particularly around the demand on services, including urgent care, and I'll touch briefly on where we are from an elective position also. I think everyone's obviously familiar in terms of the last few years and obviously the impact from the pandemic that has had, but obviously now we're moving much to a more normalised working with and alongside COVID and that more business as usual approach now. But just by way of background, in 2021, obviously just still focusing on the urgent care kind of pathway, that we put a number of measures in place, starting really from November 21 with the introduction of a new emergency care centre, and then later in the calendar year in December we opened a new modular ward block with 2 inpatient wards in there to increase capacity on site. In parallel to that, that then allowed us to move the site around to include what we reference a number of SDEC services. So that's the same day emergency care approach around acute oncology, medicine, older persons, SDEC as well, and we've got a new facility within head and neck also. So a number of kind of estate changes that the module allowed us to undertake, with, as I say, then allowing a much more ambulant focus rather than needing to admit everybody. That's further been complemented into this calendar year with a number of initiatives to support that, and that is around things like fit to sit, so where people are able to sit and don't require stretchers, etc. We've got a number of facilities where we encourage that fit to sit approach. To support timely flow, we use a system called My Next Patient, and that is supporting that early discharge from wards, and equally then people that need that admission able to get that in a more timely manner. Other things that we support in flow and urgent care with around a prescribing pharmacist in our discharge lounge, again to support take-home medication upon discharge. And actually more recently, we've just been doing a pilot with colleagues across the whole system really, and that is around call to converse, and that is rather than ambulances coming without kind of looking at alternatives to our ED here, that actually the call to converse is having a conversation with the right person, whether that's an acute medical consultant, an emergency department consultant, or actually colleagues from the community, to ensure that the care that is required when an ambulance arrives at an individual's house that we are able to get them to the right place, and that isn't always necessarily within the emergency department. So we've done a number of pilots now, so the team are triangulating the outcome of that to be able to right size and see what is required to sustain that as we look forward. I've referenced timely discharge a couple of points, but that is a key focus within the organisation, and supporting. We have an endeavour around discharge before midday, and to really support driving the main cohort of our discharges happening earlier rather than later on into the evening. And some of those things that I've just referenced all support that timely and early discharge. All of this can't be achieved without partnership working, and we continue to work with colleagues across Portsmouth and South East Hampshire in a very cohesive way. And we reference obviously the admission avoidance piece, so that's care that then doesn't require attendance or conveyance in the acute sector. We have got a piece of work around obviously the acute flow from an in-hospital piece, and then it's community capacity and discharge. So there's this kind of three main components to our partnership working across, as I say, the whole of Portsmouth and South East Hampshire. From an elective perspective, we're actually in a comparatively positive and strong position. And obviously from a prioritisation perspective, our clinical colleagues routinely now review and prioritise obviously the capacity we have from that planned care perspective. And as you would expect, particularly around cancer and those that require that urgent treatment. We've got a number of initiatives supporting additionality, so there is a lot of outpatient services functioning over a weekend to obviously support driving down weights in the timeliest possible way. And actually the main endeavour in the first instance has been around people who are waiting on waiting lists over 104 weeks. And I'm pleased to say that we have actually very minimal over 104 weeks, and actually as I sit here today there is one which is due to patient choice, and that individual is being treated next week, as I say, per that patient's choice, not because we've not had the kind of capacity to be able to do that. So again, that's in a favourable place when we compare and benchmark to other organisations. Just moving on, I'll just quickly mention some of the really exciting developments that have happened across the organisation, and one particular main one around our new emergency department. So the full business case for that went to our trust board in May and was supported and subsequently submitted to NHS England, and we are due to take that case to the Joint Investment Committee nationally in August. All being well and subject to their approval, construction for that new emergency department will commence with enabling work from September this year, and then that's a 2-year build programme aiming to have that handed over to the trust in October 2024, which will be a fantastic development and impact in terms of patient experience and flow that will certainly support. Other areas that you may be aware of and have noticed, we opened a new chemotherapy unit within Fareham Community Hospital, and that is offering additional treatment capacity for those individuals that require chemotherapy, and obviously much closer to home. So that's a great development. We've recently opened a new pharmacy, and that's operated by Lloyds, and the endeavour around that was supporting actually reducing the length of time that people were waiting for prescriptions. Other points just to kind of reference, we were lucky enough to be chosen as an early site for a community diagnostic centre. So we've undertaken our year one of that, having additional diagnostics out in venues such as Rodney Road, St Mary's and Oak Park. And actually we are just in the process of submitting our year 2 to year 5, which will build on that year 1 development and see things like CT and MR in community venues. So again, you know, just promoting that care closer to home rather than needing to come onto the acute side all the time. So that's again another exciting development. And the last point I was just going to reference, as in the report, really positive that we were selected as a next phase site for the targeted lung health check programme. So that has now gone live and targeting and inviting individuals that are current smokers between the ages of 55 and 74 for that lung health check, in the name obviously for early identification of cancer, but supporting any treatment that individuals need in a really proactive manner. So a lot of exciting developments there, and particularly obviously supporting as well that urgent care pathway particularly. But I'll pause at that point and happy to have questions and discussion. Thank you.
Thank you, Chris. Councillor Agate, I see you've got your hand up.
Thank you, Chair. Yeah, had personal experience, and I had I got dragged into my doctor's the other day, and he told my wife to drive me straight down to QA. He wouldn't wait for an ambulance. No offence, Tracy, but he said you could be spending some time sitting outside in the ambulance. So went straight into the emergency department, and I must admit, very slick, straight into triage and straight onto a bed, and eventually trundled up to your new was it what do you call it, medical village on D.
Yeah.
3 days in that, 4 days in E8, which is respiratory, and then somebody coming through and said, well, off you go, you can go home now. Oh, right, okay, yes, but we need your bed, so you're going to have to go and sit out in the hall. Nobody mentioned anything about a discharge lounge. I'm sure there must be someone there somewhere, so to call the wife, and I'm sorry, you can't go anywhere until your medication's turned up, which was about 3 hours later. So, and the hall down by E's reception area. So I think perhaps that needs slimlining a bit. But other than that, I think you did rather well. Thank you.
Thank you for the comments. Actually, with some of the points I was referencing, seem to some of the points where you did experience some of those delays, particularly around obviously the take-home medication and making sure that we are focusing on reducing the time that takes to become available. And my only kind of explanation around not being offered the discharge lounge would be around that being potentially full at that time. So we are working towards actually ensuring that we've got the sufficient capacity to be able to offer that facility to everybody as well.
Keep going. Done well so far.
Thank you. Councillor Richardson. You're on mute.
Very interesting report, and thank you very much. There's lots of good work being done. My question is a bit similar to Councillor Agate's, in that I'm just wondering how much, when you talk about collaboration, how much you were talking to primary care, in particular your GP colleagues. Some of my experience is that people are going into hospital that don't necessarily need to go into hospital. Are we seeing an increase in that, maybe due, because I don't know the figures, to GPs not being able to see as many patients for whatever reason since the pandemic? Is work being done in that area? I know that some GPs are talking about going to hub working. I've heard that. So are there not going to be as many appointments available in primary care? And are people ending up basically on your doorstep because of this?
Yeah, and I might reach out to other colleagues that are here today, but I think that the point that I would reference is that we work in a really cohesive way across Portsmouth, South East Hampshire, and obviously some of the buckets that I referenced in terms of where we focus our work is actually around that pre-admission and admission avoidance and whatnot. So that absolutely brings in colleagues from primary care. What I will say is that we equally work with primary care as well, supporting activity on site as well. So we can have GPs working here to support that actually primary care lens. So in terms of that partnership working, the point probably I want to reference is that is actually quite strong and, as I say, working cohesively. With regards to some of the detail and GP primary care capacity, I might just defer that to Joe and bring Joe in at that point, if that's okay.
Yeah, thank you.
Hi, thank you, Chris. Yeah, happy to come in on that. I think as Chris says, we work really closely in partnership across the system. We are seeing an increase in demand for care as well, and obviously through the pandemic, practices have been hit as well with staffing issues around staff sickness as we've gone through COVID, and we've had increased demand right across the board. So we continue to work really closely at all levels on that with our local GPs, but also with the Hospitals Trust. And later in my report, I've got quite a lot of detail around what we are doing, particularly in Portsmouth City, around attracting increasing roles into the city, supporting GPs, and remembering that it's not just GPs in primary care, it's a whole team, a whole workforce. That in terms of the hubs, one of the things that we are doing, again in support of that urgent care pathway, is recognising that whilst there is pressure on general practice across the board, we've created what we call local clinical assessment services, and they support the ambulances and the 111 providers, so that when someone gets a disposition of either a 10 DD or call an ambulance or lower level ambulances, we use our primary care clinicians to step in and to redirect patients and to push them back, or to put them back into primary care, and that's been really successful in reducing demand on the trust. And we also have a GP line for paramedics, and that's a single number across Portsmouth and South East Hampshire. So there is definitely pressure in primary care. Our numbers of appointments have gone up significantly, but also demand is increasing as well. And as a result of the pandemic, we're continuing to look at lots of new ways of patients being able to access primary care through e-consult, through electronic, online contact, through virtual consultations, telephone triage, etc. But face-to-face appointments are increasing as well.
Thank you very much.
Thank you. Councillor Briggs.
Thank you, Chris, for that report. It was quite positive, actually. One of the things I was really pleased about was reading about the pharmacists being more readily available on the wards, because I think that's always been one of the reasons the discharges haven't happened when they should. And I just wanted to ask why the cut-off at 74 for people with breathing and still smoking, because we're all living a lot longer now. That just seemed to be a funny age. And just before you answer that, my other question, Councillor Richardson has just asked, because I don't get so many complaints now, you'll be pleased to know, about ED, is all because people can't get to see a doctor or even get through to make an appointment. And I think in my area, run by the Vine Group, we are going to have a large hub sometime, which will be good. But it's still very upsetting for people that they just can't get to see a doctor, or they're quite happy for a consultation online. But if you're still working and you're told to ring at 8 o'clock and by 9:30, you haven't got through to your surgery, and by 10 they're not taking any more. But I go back to, I think in general, that was a good report. But if you could tell me why the 74, please.
Yeah, and I probably need to defer to the national team in some regard, in the sense of that this is a national piece of work that we are working with the national team on delivering it. So we're not the first phase to do it. We're kind of the next phase, and they're the national parameters that have been set as part of this programme. I'm sure there is analysis that has supported that this being the kind of group to focus on, but maybe that's a question that I can try and find some more information out and report back to you if that's okay.
Thank you.
Thank you. Councillor Agate, did you have another question?
Yeah, there is, I don't know if I'm in the right agenda item, but there was a pilot to support Petersfield Urgent Treatment Centre. It doesn't say when it's going to be starting.
A pilot to start what at Petersfield? I'm not sure what that is in reference to. I'm sorry.
It was a pilot to support Petersfield Urgent Treatment Centre. It didn't say, didn't state a start date. I think I'm in the wrong agenda item. My apologies.
We have done a lot of work in Petersfield and ensuring that what was the minor injuries unit there is an urgent treatment centre, which it is an extended opening time. So that's up and running. I think I haven't checked the report, but what you might be referring to is there is some work going on looking at how the urgent treatment centre, particularly in Petersfield where there's been a specific need, can work more closely with primary care in that area, and that work is sort of ongoing. So they're sort of testing a number of new approaches and how the treatment centre and primary care can work more closely so that patients get the right treatment in the right place sooner, rather than what seems to be happening, people perhaps going around the system a little bit. So that might be what you're referring to, but it's a sort of an ongoing partnership way of working that they're testing.
So that's all in operation now. Good.
Yeah.
Thank you.
Councillor Heaney.
Thank you, Ian. Chris, you mentioned expanding capacity in your brief outline report. What are the constraints on increasing capacity? Is it space? Is it staffing? Mixture of both? And how far can you go in terms of increasing capacity?
Yeah, so a good question, and actually, you know, as part of our kind of plan last year, we did have that opportunity in terms of increasing that capacity. So that brought a number of additional care spaces online in the physical sense. But you are right to reference that actually you do get restrictions in terms of at times being able to easily open more capacity when you've obviously got the workforce that is required to do that in a safe manner. What I would say is that actually, as we look forward now, there's little opportunity in terms of physical estate that we currently have on the QA site to open additional bed capacity as we look ahead into the kind of coming winter. Hence, our focus has been very much around ensuring that we have pathways that avoid admission where appropriate to do so. So that, as I mentioned, the same day emergency care approach, which is still around ensuring that people have access to specialist care, but don't necessarily need to do that from an inpatient bed perspective. So we very much focused on part of increasing our capacity to support our occupancy. And now as we look forward, it's around embedding the pathways that we've put in place to really optimise them, and the things that we've just been referencing around the admission avoidance and then the community capacity as well. There is ability to potentially look at capacity from a community perspective with our community partners and providers, which obviously supports the whole pathway on a more holistic whole level.
Thank you. Councillor Atkins, I think you had a question.
Thank you. Thank you, Chris, for your report. To what extent, I wasn't quite clear, what extent is COVID still disrupting services and delaying sort of elective procedures? And to what extent is it still affecting sort of staff numbers and availability? Or are you back to business as usual, or is that not the approach currently being taken in the hospital?
No, good question, and particularly relevant at present, actually. So I think you'll be familiar in terms of, if I think around prevalence rates, I think we got down to kind of sub 100 just a couple of weeks ago. But in the last 2 weeks, we've seen that increased from 100 to 160 to, I think it was 179 per 100,000 population just yesterday. So we are seeing that small uptick in terms of community prevalence. That then there is no surprise that as a consequence that then sees that there is an uptick in terms of those patients within the organisation, that we got down to about circa 20 patients who had COVID within the 7 day of their admission, and that has actually more than doubled in the last couple of weeks. So we are seeing a small increase, albeit still relatively small numbers, but we have seen that increase now to kind of around 40 from, as I say, that 20 number. And so that does create additionality in terms of demand within that urgent care pathway. However, at present, we're not seeing the significant impact electively. So we are protecting that, but it's a good point that we keep abreast of, really.
Thanks.
Thank you. Any more questions for anyone? Thank you for your report, Chris, and thank you for presenting to us. You're welcome to stay if you want, but we won't be offended if you leave. Next item on the agenda, item 6, adult social care. I think Andy Biddle was going to present, but I'm guessing Mark.
Yes, Andy Biddle was going to present, and I think I'm the 4th reserve, so apologies in advance.
Thank you for coming.
You've got, if you had to do slides on a presentation on adult social care, it'd probably run into 50 slides. So I don't want to go through this report in great detail, and I want to give you the opportunity, obviously, to ask questions about particular things. I can't promise, of course, to know all the answers, but I can say I'll go and find out. So I'll go through it bit by, if you want me to go through section by section and pick up questions, or if you want me to go through the whole thing and then
if you just give sort of a brief update, and then we'll take questions at the end, if that's okay.
Yeah, okay. So I mean, the first section is an overview of what adult social care does, and I did want to say something actually about that, because I am the oldest member of SMT, and I've been around a long time, and what I would say is that I am very heartened that over the last 18 months we've had a change of SMT. We have a clear, comprehensive strategy, and at the beginning of that strategy is a real clear and genuine statement about values. So I say that because what social care does is something that we're trying to reinvent. So rather than, are you eligible, here's a service, we are genuinely committed to what do you need and how can that best be met, looking at your strengths, your community strengths, and kind of last of all, what is there left for us to do. So we're moving back to a much more sort of personalized model, thinking of the individual and thinking widely in terms of assessment about how needs can be met. There's been the Health and Care Act this year, and we all know the big headlines of that. That will be a pressure for us, that people will have a limit to what they contribute to the cost of their care, that they can call on us to pick up some of the costs much earlier with many more assets with them, and that we will have to come up with a cost for care that means that, to be honest, self-funders will no longer be subsidising our payments to residential care. So there's a lot of work obviously nationally going on about that. I went to an ADAS meeting for the Southeast on Monday, and I would say we're comfortable. We're reaping the benefits of having good provider engagement. So providers are having to come up with what they think a reasonable cost is, cost breakdowns, and lots of authorities are saying we can't get providers to engage. We don't have that problem. There are changes, of course, to the Mental Capacity Act, and we are again, and the introduction of a thing called liberty protection safeguards, which will have implications for us, again, resource implications for us, but we've appointed someone to that. One of the things I would say is that more than any other time than I've been in Portsmouth, we are a real organised outfit, and we have appointed 2 posts that will effectively let us project manage some of these changes in a kind of structured way. So there's the national reform. There's the changes locally with health and the introduction of the integrated care boards. The broad headline with that is that we are keen not to lose our local identity and not to dilute the excellent partnership relationship we have with health locally, and we are quite confident that those sorts of arrangements will be allowed largely to continue. So social work, 6.2, we've seen basically we see an increase in referrals and increased pressures, and the reasons for that we don't know. I think there is a general trend. I think that probably during the pandemic, family members on furlough picked up some of the slack, and I think actually sometimes other colleagues, people in health, for instance, health professionals weren't doing so many visits, and that led to a reduction in referrals. Same section talks about culture change. There's a lot talked about culture change and values. The thing that I would say is that we mean it in Portsmouth, and to be honest, it comes back for me to my social work practice in the early 90s. So we're looking at so we have some parts of adult social care, and we have for a long time, that are nationally recognised as excellent. Our learning disability service with named worker, with a person-centred approach, with an outcome-based approach, with a massive transition to supported living, with a transformation of the day service offer. Fantastic. We've recognised that in some of the other areas, our assessments have become quite reductive, quite mechanistic, and so we're trying to bring in the culture of a strengths-based approach, working with people and not doing things to people. So one of the very successful things at the moment is people bring their assessments to a forum. Health professionals are there, community people are there, and we're having time to discuss cases and come up with holistic strength-based assessments. Hospital discharge, you'll know the work around discharge to assess services that were established. One of the things that is quite interesting is the narrative around the absence of dom care. And like every authority, we were struggling with not being able to get people out of hospital because we didn't have resources in the community to pick those people up. What's interesting is just before Christmas, we had 85 packages of care that were unallocated. We now have 10. And you can speculate about why that is, but we do not have a massive shortage of dom care workers. Now, that might change, but it's been consistent for a while now. Weirdly, we introduced a new brokerage system whereby we put a package onto the website and people volunteer to pick it up. I don't know why that made a difference, but we found that packages that had been unallocated for some time were instantly taken up, and I'm not sure why that is. 6.4, let's talk about learning disability services. Again, we have a lot of pressures. We have more people coming through. We are under a lot of pressure, as with providers in other sectors, for significant increases in fees. Portsmouth has always been very mean. So when I came to the learning disability service, we were paying £2 an hour less than any other neighbouring authority for supported living. You know, those pressures were waiting to happen, and obviously there are cost pressures across the board, and that is reflected in the requests we're getting from providers. We have quite a rigorous process for dealing with those. We're opening a large 28-bedded supported living service. That sounds appalling in terms of, do we really want a 28-bedded supported living service? It's broken up into small units. It is a compromise in terms of size and scale. It's on a great site. It's fantastic accommodation. And over the last few years, we've really moving away almost entirely from residential care into supported living, with a massive increase in accommodation and really good accommodation in a lots of shapes and sizes. We've also opened an 8-person, what we used to call a challenging behaviour service, which is in Liss, which is very beautiful. It's in 2, 3 or 4 sort of bedded houses. And we have another 12-person service opening shortly, and that provision will include 12 beds for continuing healthcare. These are not in one building, and you know, if you ever wanted to come and see some amazing supported living, I would encourage you to come to Portsmouth. It's a really good model. The carer service, we've done a couple of interesting projects, but basically the story with that is that we have a very good carer service. We do a lot of representation nationally. We work on a lot of national projects. We have a carer service in-house, which is quite a rarity. So we're proud of that. But again, pressure is on that. The independence and wellbeing team, again, I'm really pleased to be able to say that we have a team of community connectors and community development workers. We are really looking to expand our engagement with community, in particular working with colleagues in health to work out, and Joe and I have talked about this in the past, about how we as different organisations engage in terms of increasing community capacity, coordinating the different kind of initiatives like social prescription, and we are using community connection a lot more creatively. And what that does is it brings in resource. So a good example is in extra care units. In the past, if I had a need that was to do with isolation, I would probably get an allocated support worker hour, whereas now we have a community connector in there who will bring in volunteers, who will think about what I can do, who will link me with my family a bit better if that's necessary, and link me with community outside. And that's generally illustrative of the approach, which is not just here's a service, here's an hour of care, but actually how could we do this in a way that's much more inclusive, that much more personalized, and actually works out well for the budget. And I think that's our big belief, that if we do that, that's our best chance of balancing the budget. The alternative is to tighten your eligibility and spend more and more on fewer and fewer people. So that's that. We are looking, we've just appointed a couple of posts. One of them will be really integrating our offer with the Hive, because the Hive is represents the voluntary organisations, and we still are too far apart. 6.7, and I'll speed up a bit without talking too quickly. Participation and engagement sounds very woolly. There's a lot of talk about co-production, and it's a word I'm beginning to hate. It's a word it's something that will be looked up very carefully in terms of inspection. We are completely committed to the principle of nothing about you without you. So we are looking at an incremental approach to involving service users, their families, providers in literally everything we do in a meaningful way. And the way we're doing that is we are taking an area. First of all, we're doing an audit. Authorities seem to think they do really well on co-production. I don't believe I've come across an authority that does well in it. And we are going to say, then take area by area, develop guidelines, launch it with the staff and say, for instance, with recruitment, everybody will involve stakeholders in recruitment. This is how you do it. These are the things you need to think about. It's not an option. And gradually we do involve people in tendering, but we want people to be involved in design of services, in evaluation of the quality. So we're working with people and not doing 2 or 4 people. And I think that's the big message. And I think one of the things I love is we mean business and we're honest about it. So actually, if we have a situation where we're not giving decision making to the service user, we say that at the beginning rather than pretend and play at it. So we've got a participation lead, we've got a community engagement lead, our fora, I think, are really active. And a really good example is how we've begun to work with autistic people. A lot of authorities have struggled with how do we support people who may be eligible or not eligible, who may dip in and out of eligibility. So we've had a really good forum. I would think 50% is at least 50% are autistic people, and then families. It's chaired by a mother. When we wrote a report about what needed doing, it was presented by the mother with one of our staff. We asked people what they wanted. One of the things they wanted, and we're doing a number of things, including appointing social workers, specialist social workers, is a hub where we can design services out of that hub. So we designed it with people. The autistic community is designing what happens. 2 autistic people are employed to run it. And it just feels a really lovely illustration of doing something in partnership rather than us not doing anything or coming up with a bad idea. It means we will provide supports to people who traditionally wouldn't be eligible for social care. But again, I go back to our belief that if we involve people in this stuff, overall the budgetary pressures will decrease. Regulated and provider services, well, I don't think there's much to say about that except we have them. Dom care I've spoken about a bit. We have to come up with a lot more information and we're investing in that. Again, DOLS, deprivation of liberty, an increase, safeguarding, an increase. One of the very successful things that I think that's happened with safeguarding is we used to get a lot of concerns from the police. So you can't see the wood for the trees because you literally, I think it says, we literally received over 2,800 referrals, PPNs from the police. Wading through those is impossible. It diverts the energy of our team. We've worked with the police to really reduce that down. Complaints are fairly static. We welcome complaints. We record far fewer compliments than we get. We recognize that one thing we're behind on is policies, paper, to use an old phrase, things like a market position statement that sets out clearly to the market where we're going. Again, we've been very clear in mental health. Mental health's been very clear in learning disabilities. We've had a very clear strategy. The reason we haven't written a market position statement explaining to providers our direction is we haven't known. And so one of our priority tasks with older people and people with a physical disability and an acquired brain injury is to have a clear plan, a clear strategy. What are we doing with the housing support that we have in Portsmouth now? Where's the place of extra care? What are the demands on our service and how do we propose meeting them so that we can work with providers to put things in place? We're appointing a quality assurance lead, 9.3, and we have a regular performance monitoring now. We have regular project meetings. We have a much more project approach in terms of governance, we're really on a really good journey to being able to evidence what we do and what we do well and what we don't do well, but what our plan is to put it right. And of course, behind all this is a looming inspection, which will be new to us. And as I say, I think we have a lot to put in place to evidence. But I think what we have in place now is a strategy. We're also introducing team plans where the strategy is embedded in people's teams. Teams come together to think, what's the strategy telling us? What do our stakeholders say? What are their priorities? What are our priorities? What is our plan? So we feel much more on it and much more together. So in summary, I think we've got a lot of cost pressures. I think we've got a lot of increased activity across the board. I think we've got a lot of inflationary pressures and the fair cost of care. So that's all uncertain. But I think in terms of us being cohesive and together and having a plan, I think I'm very encouraged. And I'll stop there.
Thank you, Mark. Does anyone have any questions for Mark on the report? No?
Does that mean you're all bemused? Or
Graham, you got your hand up?
I was quickly looking for my sign hand, but couldn't find it. I wanted to ask a question about the spike in the referrals. And I think you might have said you didn't know, but I'll just double check. The graphs on page 31 and 32 show a big sort of spike from March 21 through to, well, it's February 21. It begins to fall again. I mean, are these likely to be COVID related referrals, issues coming out of COVID, or do we just not know why that's been that?
Well, no, we don't know why. I mean, in referrals across the board, if you take an area like learning disability, we know we're going to get more referrals because we know that there are more people with complex needs living longer. If you look at the direction we're going to get more referrals because, to be honest, in the past, someone with autism would think there's no point going to social care. We've done a lot of work identifying people in transition and actually saying, well, we think some people might be eligible for social care, and we give that message. So people often used to talk about autistic people are not eligible for social care, but perhaps we could help. Well, to be eligible for social care, there are certain criteria. One is you find relationships difficult, you find work difficult, you find looking after yourself difficult, you find integration into community and being independent difficult. Sorry, that's quite a definition of autism, the issues that autistic people face. So I think as we become more open, and we communicate better, I guess we're going to get more referrals. But I think we're speculating, as I say, that during the pandemic, it kind of flattened demand because, as I say, quite a lot of referrals from health professionals who pick up when they visit, and visits weren't happening in quite the same way. We weren't visiting in quite the same way. Also, a lot of people were on furlough, and I think people probably coped and then went back to work and thought, well, actually, what are we going to do about mum, because we need help here. But I do think there's a general trend. Okay. There's a general demographic trend anyway, isn't there, nationally, in terms of older people, but also interestingly, in terms of cost pressures nationally, that's equaled, if not exceeded, by people of working age with disabilities.
Okay, thanks. That's very helpful.
Thank you. Are there any other questions? No, I think that's it. Thank you, Mark.
No, it's a pleasure. Nice to see you all.
Thank you.
Thank you. Bye-bye.
Next item on the agenda is agenda item 7 from Public Health. Is it Dominique Latouze?
Hello everyone, I'm Dominique Latouze. I'm Assistant Director of Public Health. I'm here on behalf of Helen Atkinson, Director of Public Health for Portsmouth. I think in the papers you've got the presentation from Public Health, which is a general update, and quite a nice opportunity to give a general update, having had a few sessions of COVID focused updates. So now this is a little broader than the previous presentations we've given in the recent past. So I'll go through sort of very briefly the slides, and then I'm sure you've got questions on that. So I would like to share my slides with you. So in terms of the contents, you've got that there. This is a really, like I say, a broad overview of where we're at with public health in Portsmouth, and you'll see there the real range of topics that public health is involved with. Well, I'll start with our mandated services. So in 2013, when public health moved to local authority, there were a number of mandated services that come from the ring-fenced public health grant, which include appropriate access to sexual health services, which includes contraception services, sexually transmitted disease testing, and treatment, HIV testing. We need to ensure that plans are in place to protect the health of the Portsmouth residents, which we've done a lot of through COVID, but it also includes immunisation and screening plans. We need to ensure the CCG and subsequently the ICS receives public health advice they need to support their commissioning of services, which we refer to as a core offer. That involves the National Childhood Measurement Programme, testing the heights and weights of reception and Year 6 children, NHS health check assessments of those 40 years and above, and some prescribed children's 0 to 5 services, and commissioning local health watch. And in terms of our business plan and priorities for this financial year, these don't change very much year on year. Obviously, they're very long-term goals. Our 7 priorities this year are to reduce the harm caused by substance misuse, which includes alcohol misuse, reduce the prevalence of smoking, which would include smoking in pregnancy, and we work in partnership with many other agencies to ensure that system-wide action. To reduce unwanted pregnancies, we're increasing access to long-acting reversible contraception or LARC in GP and maternity and abortion or termination pathways, and strengthening those pathways with particular vulnerable groups that we know are at risk. Promoting positive mental well-being in Portsmouth and reducing suicide and self-harm in the city by looking at delivering the suicide prevention plan that's currently being refreshed, and the STP suicide prevention plan, which obviously will be replaced by ICS plans as well. Promoting healthy weight, particularly reducing the harms we know exist from physical inactivity and poor diet. Working with council and other partners to address the health impacts of the built and natural environment, and that might include things like flooding, climate change, air quality, and other factors associated with environmental health risks. And finally, to really underpin all of that by enabling an intelligence-led approach, an evidence-based approach to addressing key health and care priorities for the city, and of course supporting the ongoing response to COVID. So I touched briefly on commissioned services there, which I won't list again, but you've got them there. In addition to those, we're also responsible for locally commissioned services, LCSs, which are NHS services that provide a response to local need, sometimes adopting national service specifications, and they include, in addition to what we've already got, further provision for sexual health, smoking cessation, health checks and substance misuse relating to alcohol and drug misuse. And to give a bit of detail on some of those, just to update you on our commissioned services. In terms of locally commissioned services, we recommissioned those in April 2021, and they're paid for by activity on a patient-by-patient basis. Health checks is the only one that's, as it's invitation only, it's slightly different and paid for through a block contract. LARC is provision is being supported at the moment by some quality improvement work, which I'll touch on again in a few minutes. The Integrated Drug and Alcohol Treatment and Support Service has recently been recommissioned, and the new contract was awarded to the current provider, Society for St James, SSJ, and they're working in partnership with the NHS provider called Inclusion, who provide drug and alcohol services across the country. So it's a nationally run organisation with national expertise. Additional elements within the new contract, which is substantial, and I'll again touch on that in a minute. We've had a lot more funding for that, which has enabled us to do much expanded opening hours to 7 days a week, which should serve users really well, expanded women-only provision, and expanded support for carers and families. We've been able to provide some alcohol-only provision and deliver some abstinence-based supported housing. So really some much more wraparound support dedicated to or shaped towards service user needs. In terms of sexual health, that contract started in 2017 and is run as a joint contract across Hampshire, Portsmouth, Southampton and Isle of Wight local authorities and CCGs, soon to be ICS. Solent NHS run that service, and the mainland local authorities, so Portsmouth, Southampton and Hampshire, have the ability to reconcile at year end, and we make claims for underactivity if necessary. That does also include the provision of PrEP for HIV. And I mentioned the system syncing review, which again I'll talk about in a second. In terms of health visiting and school nursing, Solent NHS Trust deliver that through and by Children's Services, which we pay through a Section 75 agreement, honouring our mandated need to do that. There's clearly a sort of a real partnership there to deliver those services. And finally, Health Watch was recommissioned last year in April 2021, and the new contract is with the advocacy people. In terms of our COVID response, we had a range of offers, and I know that you'll have heard a great deal about that over the last 2 years, so I won't go into a lot of detail now. We had a public health advice rota that gave advice on public health, the so-called consequences of outbreak and infection, which is the local authority role, as opposed to the UK HSA, the UK Health Security Agency Health Protection Team role, which is much more involved. We were able to do a lot of comms and translating of evidence and advice for local populations through our comms work. We've worked really intensely with partners across the whole health and social care system and the local authority system to develop a response. And also used our intelligence to model findings and share all of that with partners, that epidemiological information. We have been part of and delivered test and trace programmes working with national government and UK HSA, UK Health Security Agency, and also supervised and supported the management of local outbreaks. And currently where we're at is on shaping our local living with COVID plans. We're waiting for the UK Health Security Agency to deliver the national plans for living with COVID, which we're expecting any day now. And like I say, the response for coming surges, if they should happen, would be led by UK HSA, but we would be managing, or we'd be presumably asked to manage the consequences of outbreaks in the city. And what we've got is a great suite now of standard operating procedures, of plans, of operational guidance that we can now draw on from our experience over the last 2 years. So and all of that amazing partnership work that we've built on. So we're not going to lose any of that. We're going to keep that sort of secure and ready if we need to stand it up again. In terms of joint working,
as I said, we do a great deal and have done with Portsmouth CCG and through the Health and Care Partnership and Health and Care Portsmouth. We have merged commissioning functions where appropriate through some, and I mentioned the Section 75 agreements for children's, which involves sharing resources where possible, and the potential to pool funding on programme areas where that would provide a dividend. And the main benefits that we've found from public health services to improve the outcome for residents are really that we're able to better join up services, for example, with sexual health commissioning, removing any barriers to funding and provision that might exist only sort of structurally, not really in the minds of residents or service users.
We've given the opportunity, it's been given us the opportunity to join up, improve the join up between mental health and substance misuse services, and develop really strong links with the homeless primary healthcare team, which I'll come on to talk about in a second. And we've been able to link and support the primary care networks as they develop jointly agreed patient group directives on different prescribing. Strengthened intelligence has been a real boon through these efforts, including supporting the intelligence-led population health management approaches, providing maps and analysis, and engaging the CCG in joint approaches like to shared key challenges across the network through the knowledge network and modelling stakeholders meeting and so on. In terms of public health intelligence, like I said, it really is the bedrock of everything we do, and we've been able to present that intelligence through the last 2 years. Has given us an opportunity to really show how we can share that intelligence to the best use of everyone, all partners. Working to share particularly COVID-19 data and intelligence through the local outbreak engagement board, the health protection board, Portsmouth City Council's Gold resilience stand-up meeting, through member briefings, through the Hampshire and Isle of Wight Local Resilience Forum Recovery Coordinating Group, Health and Care Portsmouth Care Home Support Meeting, through operational activity, like I mentioned, through the local contact tracing service, and obviously, most importantly, through comms with residents, through the website and social media and other fora. In terms of further joint working on violent crime, we integrated community safety analysts into the public health intelligence team last year in January. And that's enabled us to produce an annual community safety strategic assessment for Portsmouth that really informs local partnership efforts in that area. We're still continue to support the implementation of the serious violence strategy and looking at further research on that topic. And we regularly receive and analyse data on violence, drugs and alcohol related activity in the ED department at Portsmouth Hospitals University Trust, which is really helpful because it just gives us a much richer picture of what's actually happening in the city. We've got an in-house wellbeing service that supports clients for the four main risk factors that we know create the most the greatest number of early deaths in the city, which is smoking, weight, physical activity levels, and alcohol consumption. The wellbeing service can also support with mental wellbeing. You've got the figures there, and I won't go into them in a great deal of detail, but last year we saw a high increase in self-referrals in particular, which might be understandable because obviously people were not seeing their primary care professionals as much as they might normally do. We have seen an increase of referrals of over 100% in the last year. And I suppose that's reflected in that need that we're seeing, that we saw reported nationally in terms of obesity rises and others. But also we've seen national funding through things like the Bounce Back programme, which was nationally funded, has enabled us to increase our activity for obesity management, for example. In terms of support provided, we saw 2,159 clients for smoking support, of which nearly half set a quit date. I think it takes on average around 5 times to quit, so that explains some of those figures. 327 clients were seen for weight management support, 18 for alcohol support. Don't forget also that there's more in-depth support through different alcohol services in the city, and those figures are all there. So in terms of homelessness and health, as I mentioned, Portsmouth's been awarded additional funding for homeless drug and alcohol treatment from now until 2025, and that is substantial, and it's going to be funding a team of staff to engage and support people with complex needs, including psychological and mental health support for those with coexisting conditions. And that we're expecting that there'll be additional funding for inpatient detox and residential rehab for this group as well. We've been awarded additional funding from NHS England to provide specialist homeless mental health provision, which will build on and complement that drug and alcohol funding provision that I just mentioned. We've been working closely with the CCG to develop a sustainable homeless primary healthcare team, and that's been a long time coming. It really builds on pilot work that has been underway for several years. And linked to that is some of the work we were able to do with the COVID-19 vaccinations of rough sleepers and homeless people living in hostels and other accommodation during the pandemic. And when we were housing people through the Everybody In initiative in the first phase of the pandemic, that first lockdown in sort of March, April, May 2020, the homeless primary healthcare team was able to have a presence in those hostels. And through that, we were also able to deliver TB and bloodborne virus screening of those people in that location in partnership with the UK Health Security Agency. And that was nationally picked up as as an example of good practice, and picked up and I think won a Nursing Times Award for innovation. And then continuing that work that we built up, using that sort of innovation that we developed during the pandemic, continuing to work closely with PCC Housing and the third sector to provide advice and guidance on homelessness. In terms of substance misuse, we've got around 1,540 heroin and crack cocaine users in the city, and around 4,000 alcohol dependent people. 1,436 people accessed drug and alcohol treatment in the last year. So a substantial proportion, you would hope, of those heroin and crack cocaine users. And the annual treatment spend per annum for the city is 2.5 million. But as I mentioned, since 2021, 2022, there's been significant additional government investment for work with rough sleepers and criminal justice clients, up to £1 million. And this funding will be, as I just mentioned, will be further enhanced over the next 3 years with ring-fenced funding, which is taking, although it sounds like a lot, is actually taking it back to 2012, 2013 levels. So we're really able to enhance the provision in the city that we'd seen slightly falling over those years. And just to put it into context, although it sounds like large numbers compared to our budget, actually drug and alcohol treatment saves or reduces the costs elsewhere between £4 and £9 for every £1 spent on it, in terms of the costs that would be incurred through criminal justice, social care, healthcare, and all the unmeasurable costs to human lives and families. In terms of sexual health, I won't go through all of the details here because I'm aware I've probably been talking already for quite a long time. There's quite a lot to get through, so I'll let you have a look at those figures there. We do continue to have quite a high STI, sexually transmitted infection testing rate, but also a high positivity rate for STIs, which is the second highest in the southeast. But those are at least being picked up because we've got such a high testing rate. We were able to maintain LARC provision in primary care despite a national dip during the pandemic, during the early phase of the pandemic, again through an example of innovation, through online and telephone consultations, which again was an example of how things had to shift because of the changing nature of the delivery during the pandemic, but gave us some really opportunities to really innovate there. So that's a sort of good news story, if you like. In terms of partnership working, as I said, this is delivered through the Children's Public Health Strategy, which runs until 2023, with these 4 long-term strategic priorities and visions about giving the best start in life, thinking really in utero and in those early first 1,000 days, to focus on thriving parents, enabling parents to parent in the best way they can, addressing and understanding the impact of poverty and on what that and the impact that has on young children and their ability to develop good physical health. And environmental and social planning, thinking about how the built environment and healthy place shaping can be embedded in physical health of children. For example, addressing things like air quality, addressing access to green space so that children can play safely and in green and blue space that they enjoy. Childhood obesity continues to be an issue in the city, although we don't have substantially different to national average figures in the city. We've still got it's around 1 in 4 children are obese or overweight at reception, rising to 38% of children in year 6 being overweight or obese, which, although shocking, is actually quite comparable to national figures, but still clearly an issue that we need to address. So we launched a so-called Super Zone pilot in September 2021, which was a relaunch from March 2020. The idea behind that is that it coordinates policy and practice around some of the drivers of childhood obesity in one specific area around one school in Portsmouth, Charles Dickens, Arundel Court Primary School. So the 4 themes there are healthy food, active places, clean air, community safety. And that's going really well. And I can take questions on that, but I don't have much time to go into it in a great deal here. So we'd continue to deliver family weight management via the wellbeing service. We've got a new physical activity strategy, which is for the whole of Hampshire and Isle of Wight, but including Portsmouth, which was published this time last year. And we are doing joint working with key professionals on childhood obesity as well. And there's a new national childhood obesity campaign launched in 2022, which we're supporting as well. In terms of mental health and emotional well-being, there's an expectation under the current cost of living issues that there'll be an increase in debt, which may lead to mental health distress, and so that we're working to support debt advice services to ensure that the system screens for mental health and wellbeing issues. We're working with mental health services providers to that's a repeat of the last point. We're building capacity and anticipation of an increase, as I said, in low-level mental health and emotional distress across the city through things like the Connect 5 training, which is mental health training. We're reviewing, as I said, the Suicide Prevention Action Plan, which ended last year. And one of those actions is looking at local real-time surveillance for those particular trigger points for suicide sites, such as railway bridges and so on, and also provides a means to offer timely support who have been very recently bereaved or affected by either suspected or actual suicide. And locally, we're doing a great deal of work for children and young people who are bereaved by suicide as well. Briefly then, in terms of we're doing a great deal of work across the council on these so-called wider determinants of health. So that includes work on air quality, on climate change, on greening the city. Air quality, one of the work streams of the health and wellbeing strategy, which was adopted in March or February this year, is to deliver to improve air quality in the city. So we now have a board that's set up to deliver that. That's multi-agency, which I think is really exciting because it means we'll be able to. It's air is like cigarette smoke. It doesn't poor air quality and pollution is like cigarette smoke in that it doesn't restrict itself to organisational or administrative boundaries. So working together on that's really, really crucial. We're doing a great deal to support the Climate Action Board, and we also have a new Green and Healthy City officer who oversees greening, the city greening strategy that's funded by Public Health. In terms of supporting transport, we are members of the Local Transport Plan 4 working group that brought that plan to fruition and provide public health intelligence on a number of other transport plans. We're also supporting planning to think about how we might get health on the agenda in terms of strategic planning for strategic developments, for example, thinking about health impact assessments and how we might use those to understand the long-term health impact of development in the city. I'm going to pause there and end the slideshow and come back to you. So I'm happy to take any questions.
Thank you. Any questions from anyone? You mentioned that there are approximately 1,500 heroin and crack users and 4,000 alcohol dependent people. How does that compare with previous years? Is that increasing, decreasing, or is it fairly stable?
I would have to look up the figures to compare it to previous years because I don't have those at my fingertips, but I think that figure hasn't substantially improved over the last few years.
Okay, thanks. Anyone else? No? Oh, Councillor Briggs.
Thank you. Having trouble with my hand up and hand down today. Public health is a huge remit, isn't it? And I could ask so many questions on it. And you have covered it, but even before you said it, I wrote down air pollution. Portsmouth is one of the most heavily air polluted cities. And it affects children very much, babies in the womb. How are you going to go about it? And also to connect with the question, greening up Portsmouth. I was born in Portsmouth. I know Portsmouth very well. It's densely populated, like lots of places. So how are you going to green it up? We all want children outside playing, and that leads to them not being obese. It's a really general question. You've got so much in that report. How are you going to do it all, please?
Thank you. Yeah, and it's right. It is, and it's those, like I said, those so-called wider determinants of health are so important. And I think that it's really coming to the fore now that air quality is so crucially important for our health. And I suppose the first answer would be, we public health aren't going to do it. We, HOSP and others, are going to do it. And it needs that coordinated action, I think, across several fronts. And what we in public health can provide to support that is that really strong evidence base about the figures, understanding the scale of the problem and also what works to improve it. So we know that for example, one of the things that we're doing for the Air Quality Board locally is to support the ICS Green Plan, the NHS Green Plan, and looking at air quality and active travel. I think that one of the first actions we're doing is to understand all of the different air quality plans that all of those member organisations have, which includes Portsmouth Hospitals Trust, Solent Trust is on that, Portsmouth City Council, the Navy, the University, the Port. We've got Sustrans and other bodies on there. And our first piece of work is really to get all of our air quality plans together and understand where the similarities are and where the gaps are. And I think that so that we can really understand how we can kind of drive forward something that's greater than the sum of the parts, because I think we're all working on very similar issues. For example, we know that transport at the moment drives, excuse the pun, around 50% of poor air quality in the city. So we will need to really address transport pollution and promote active travel. If all of those organisations, if we were to coordinate all of the action in all of those different organisations, we'd get a lot further than we will do just by working individually. And then in terms of the obesity you mentioned and children playing and other things, that's one of the rationales behind the super zone. So I just talked about a very macro approach. At a very micro approach, one thing that we're trying is to, and you mentioned, Councillor Briggs, all the different co-benefits, if you like, from all of these policies. So maybe a number of these policies have similar outputs and different outcomes, but similar approaches. So you might so the super zone focuses on coordinating those policy and practice for clean air, for active physical activity, healthy eating, and community safety, because that's another really important factor about why children don't want to go out and play, is that they don't necessarily feel safe, which was the research that we found before we did the project. Coordinating all of that policy and community action around 400 metres around a single primary school, and we found that what's our early findings are that the school are really keen to take part, but many of the single actions that we're taking are having multiple co-benefits. For example, when we asked children to how they felt about their local environment as a means to becoming physically active, for example, they said that they didn't feel safe in their local park. There was a lot of drug use that they saw. There was a lot of dog mess and other things that just meant that they didn't really feel able to, and they wanted to go to the local park. So we've worked with colleagues in the council and in community organisations to regenerate Arundel Park based on what the children said, and it's a much nicer environment. And so the next piece of research is then to go back and say to the children, well, now, you know, is this what you wanted? Is this going to help you to kind of actually get out into the park and use it more as a very kind of micro attempt to address all of those multiple issues that will hopefully start to think about addressing obesity in the city. So it is a highly complex issue, but I think it's something we all want to work on, and therefore we've got really good will.
Thank you for that. It is important that children can play safely in parks. I spent my childhood in College Park, so yes, please do carry on, that children can play safely and happily. Otherwise they won't prosper. Thank you.
Thank you. And any other questions for Dominic? No. Thank you.
Thank you very much.
Next we'll move on to item 8 on the agenda, South Central Ambulance Services, and Tracy Redman. Welcome.
Good afternoon. Thank you. Thanks for the invitation. It's nice to be back. I apologise for missing the last couple of invitations. Maybe it will be revealed as I talk through where we've been over the last year or so. In terms of my report, obviously there's an overview at the beginning, which I think most folk are familiar with anyway. As an organisation, we cover from Milton Keynes down to ourselves here at the coast and many parts in between. In terms of the southeast area, the Portsmouth, southeast Hampshire is the geography that I'll focus on for today. We've heard a lot about COVID, and I am going to mention it because it has had such an impact on I think everybody in all walks of life, but certainly across health and social care. We've continued to work alongside national guidance in terms of changes and requirements, both for our staff and for how we look after our patients and how we keep our patients safe in terms of infection control, etc. That's changed along the way, and we've adapted and changed with it, but has brought its challenges. We're still in a position at the moment where we continue with, in terms of patient contact, the same level of personal protective equipment that we've had throughout the pandemic, and that's about keeping our staff safe, but more importantly, our patients safe, in particular those who may be vulnerable. So we continue with that level of personal protective equipment. There have been some changes around how we deploy and use our services as well. During the pandemic, we've had some challenges around the demand, the types of demand, and the staffing challenges, I think, that most health and social care organisations have seen across the pandemic. That demand does continue to be variable. We did see the drop off in COVID demand alongside others, but as Chris mentioned earlier, there's a little bit of an uptick now in some of those COVID cases coming back through to us. Alongside our sort of COVID arrangements, we've had enhanced leadership in place throughout and enhanced command and control system in place so that we can make sure as leaders that we're supporting our staff in order to deliver the service that we do with the additional challenges that the pandemic has brought us. We have been very focused on the health and wellbeing of our staff. We can't do anything without our staff. They are a key asset, and we have had a lot of challenges with staff absence through the pandemic. Without our staff, we can't look after our patients, so we continue with a high focus on our staff as we go forward. In terms of progress, we are very much part of the local system integrated urgent care and working very closely with partner organisations across Portsmouth South East Hampshire system, including the hospitals, the community services, primary care councils, etc., to make sure that the service that we deliver for the patient is what they need collectively. And we've also got colleagues who work in the SCAS emergency control room from mental health, maternity and social services. So if 999 calls come in, those experts are in the room to be able to, if appropriate, speak to those patients immediately, or at least ensure that we can signpost them to the most appropriate care that they need. So there is a focus on trying to support patients further upstream than just dispatching ambulances. So we're dispatching the right resource to the right patient. We are focused very much on treating patients in the right place, which may well be at home. A lot of our patients we do treat at home, either by immediate treatment by the ambulance paramedics or by signposting onto other appropriate treatment from partner agencies. This is done either by the paramedics on scene or by our clinicians in our call centres and control rooms. And we have had some developments over the recent year around the options we have to signpost. So the pathways, we call them urgent care pathways. So this is just around what options are available to us as a service to be able to offer to the patients to make sure that they get what they need. And those options continue to grow. We continue to review and develop those options. And we've got a digital system that continues to develop to support our staff to be able to keep up with those many and ongoing changes. And we've shared now that digital system with primary care and with our community colleagues as well, so that we're all working to a very similar system. You heard Chris mention earlier around the call to converse pilots. We've been running those for the last couple of months, which is around connecting clinicians together. So the crew will go out to the patient and they will have a phone a friend and discuss the clinical needs of the patient with either a consultant, with a community nurse. Is it appropriate that a community nurse visits? Let's phone the community nurse, have the conversation. So we're connecting all of our clinicians together to make sure that all the information and expertise is in one conversation, just to make sure that that patient does actually get what they need when and where they need it. So that's a big focus of our work at the moment, is around making sure we can do that. It's not perfect. We are still working on it. We are still developing some of the pathways, and there are still a few gaps, but we've certainly come a long way over recent times. And actually, I think the pandemic has helped us because what we've also tried to do is avoid patients crossing other patients in terms of contamination. So if we can keep them in their own home or signpost them somewhere individually, that's certainly a lot better for the patient. All of that work is around making sure the patient gets what they need, but in addition, it's around supporting the ED is for emergencies, for acute emergencies, and not for other types of patients. We do get challenges with ED, which I'll come on to, but in terms of the SCAS activity, we continue to convey less than 50% of our incoming 999 call gets conveyed to ED. The other 50-something% is either treated on scene by the paramedics or signposted to a more appropriate setting for the patient's needs. In terms of demand, demand throughout COVID and continues to fluctuate, which does make planning and forecasting a bit of a challenge. And there's just an illustration there of the fluctuating demand by month. And you will see the performance tables there, and I think most of you have seen these before, but just very briefly, the green numbers are where we have met the national standard, and the red numbers are where we have not. And the black is not nationally measured, it's just local measures. So you will see clearly that there has been a deterioration across the board for SCAS performance Q4 last year to Q4 just gone. And there are a number of reasons for that, and we do recognise that. Whilst if we add up the overall demand, actually it did go down a little bit. The acuity of those patients has increased, so we're seeing a lot more patients who are a lot more unwell. In fact, we've seen a 9% increase in our category 1 and 2 demand with the comparison on those 2 quarters. And those patients who are more unwell inevitably will take up more resource, more time, which makes it more difficult then to get to some of our lower acuity patients in a timely fashion. Clearly, we prioritise the resources that we send, and we send to the most poorly patients first. With those numbers on the increase, it has been certainly a challenge to get to some of our less poorly patients. In addition to that, we have had some significant staffing and workforce challenges over the period, as well as some ongoing challenges with hospital delays. This is a national issue. This is not a local issue. However, in our SCAS area, Portsmouth is a particularly challenged system for handover delays. And the numbers of hours that we lose, i.e. the ambulances sitting outside the department and unable to offload and therefore unable to go to the next patient, does go into the thousands, sadly. So we do recognise we've got a lot of work to do across performance and those factors that impact on our performance. But just in terms of operational pressure, it has been significantly challenging over the last couple of years, in fact, but that pressure has not ceased at all. We had COVID, then we had the post-COVID. There was quite a spike post-COVID of folk who had not been seeking help during COVID and were becoming more unwell at home. So that changed our demand profile as well. We work to a national framework called REAP. All ambulance services have to work to report their REAP level into the national team. SCAS have been operating at REAP for, actually, whilst my report says 6 months, it's probably nearer 18 total. We've gone on and off, but majority of that time we've been working at REAP for, which, as you can see, is extreme pressure. And we have declared 2 critical incidents within the last 6 months, which is essentially the next level after REAP 4, where there has been some significant risk to patients. What that comes with is a plan to, when we hit these triggers, we have a plan to focus our resources differently, to utilise our resources differently, to make sure that we can focus where we can on our most poorly patients. So there's a lot of work behind these levels and these declarations in terms of actions. With regards to the transformation review, this has been ongoing for actually for a couple of years now. It was put on hold through pandemic, but it's now back in full swing. So I'm hoping to see some further developments on that going forward. And this is about how we can be more efficient and more effective with the resources that we have, where the resources are, how many resources, and how we deploy them. So that's a key piece of work that's happening across SCAS. In terms of patient care, I think I've already mentioned our biggest focus is making sure that we get to the most poorly patients in a timely fashion, that we make sure the patients get the right care that they need in the right place at the right time. And we do continue to work with all of our partners in the system to be able to achieve that. I've spoken briefly about hospital delays, but they are a significant impact to SCAS being able to get to patients and deliver our service. They are measured nationally on a standard of 50. The ambulance arriving at the hospital, after 15 minutes, the patient should be handed over and the ambulance should be on its way to the next patient shortly after. So the time lost is measured anything over 15 minutes. And as I mentioned previously, in terms of hours lost, you can see that it does go into the thousands month on month, which is obviously a significant challenge for us. And just in terms of a slightly longer view, we can see some of the changes during COVID where things were up and down, calmer up and down, but we are currently in quite a volatile situation with it being very up and down, which again makes it difficult to plan and resource in terms of us knowing what's going to be available and what's not on a given day. So it's quite a big impact for us. We do work closely with our colleagues in the hospital, Chris and the team, as well as wider system partners. It's not just an ED issue, it's a system issue. The hospital is full, so there's impact on discharges, there's impact on inpatient flow and admission avoidance. The three areas that Chris mentioned, we're very much collaborating with to support this piece of work in the hope that it will help this handover delay position at the front door and allow us to get out to our patients in a bit more timely fashion. So we do recognise that there are a number of challenges ahead. We recognise that the performance is by no means where it should be, and we have got a recovery plan in place, which we are being supported by NHS England and the ICS and the local system around our recovery plan. And there are three kind of key phases to that in terms of the 999 service in particular. It's around looking at, we use private ambulance companies, that's not a new thing. It helps us with our fluctuating demand. So we're looking at where we can procure additional private provider hours. We continue to look at our staff absence and what we can do to support our staff back to work, and what we can do to support our staff from not being absent in the first place. We do have an ongoing focus on recruitment, including international recruitment, and we are looking at how and when we deliver our training and whether we can do that in a more efficient and effective way to reduce the amount of staff that are off of operations and on training, accepting that there is clearly a level of training that must be achieved in order for people to keep safe and competent. So there's getting that balance right. Clearly, the next one is, we call it reduction in task time. So for us, task time is the amount of time that the vehicle is on task. So therefore, from it when it's dispatched to when it's ready to go to the next job. That includes the hospital delay in the middle. So a normal task time in this area is about an hour from the time we get the call, we get to the patient, we pick them up, we take them to hospital, we drop them off, we're ready for the next job, roughly about an hour. And clearly with the delays at the hospital, that is significantly increased. So we're looking at how we can obviously reduce those delays, but also reduce the time that we spend on scene with the patients. And that goes back to getting those pathways in place and embedded so that it's easy to be able to signpost patients to the right place. It's an easy, quick and slick process, so ongoing work with that as well. And we're also looking at how we deploy our resources, including our community first responders. We've got a large number of community first responders who do a fantastic job, and we're just looking at how we can better or more efficiently utilise our community first responders. And we're looking at some of our policies and procedures to see how we can again become more efficient and effective, and as well as our dispatch processes. So just to summarise, I think it has been a challenging couple of years, and it still is, and that, I suppose that's kind of the message really, is that it hasn't got any easier. We're not post-pandemic in terms of the challenge, in terms of the demand and the capacity that we've got. Workforce is difficult. Despite that, and recognising it is a national challenge in the ambulance sector amongst other sectors, we have been able to remain there or thereabouts best in class against other ambulance trusts nationally, which is, all things considered, a good place to be. But clearly there is a lot of work to do, and absolutely recognise that, and absolutely focused on going forward now, making some of those changes and improving what we can do for our patients. I think that's about it in summary of the report. Thank you.
Thank you, Tracy. Councillor Richardson, you have a question. You're on mute.
Sorry. Hello, Tracy. Thank you very much for your report. I just wanted to say that, you know, I feel extremely sorry for the ambulance service. I think they are pressures that a lot of people don't see. I'm talking the general public, and obviously you need a lot of help and support from everybody. I'm very pleased to see this initiative called to converse. And I just wondered how easy it is to contact other professionals when your ambulance staff are out on the road and trying to speak to others. I mean, I certainly know from my own experience that it is quite difficult to contact other health professionals, district nurses particularly, because they're all out there, and everything goes through a sort of central hub as well. So I appreciate that it is quite difficult, but I wondered how well it was working in terms of contact. I can see that it's a very good initiative, but you need to be able to speak to those people when you need to be able to speak to them, and not to be on the other end of a phone, again, delayed because you can't get hold of those people.
Yeah, certainly. There are some of our well-established pathways. We've got dedicated phone lines which are set up for the crews. I think Joe mentioned earlier around the primary care paramedic line and things like that. So that's fairly slick now because it's been in for a while. Call to converse, we call to the community teams initially, and then we have a 3- or 4-way telecon with whoever else we need to dial in. Going through to the community teams is fairly straightforward. Again, for the pilot phases, we've had a dedicated line with a dedicated person on the end of it. And part of the pilot has demonstrated to us that actually there would need to be some investment to be able to sustain having a dedicated person doing that, because obviously community teams are hugely busy as well. So moving them to do this was take them away from something else. So an ongoing balancing act. So some work to do on the analysis of the pilot, but in terms of getting through, we have established and agreed pathways both in hospital. So some of the in-hospital departments like the surgical assessment unit and places like that, we've got dedicated lines into there. So on the whole, getting through is okay. But there's some bits to work on still, I think it's fair to say.
Okay, thank you. Just one other question, please, Chair. There hasn't been much talk about working with the private sector, and I'm talking here nursing and residential homes. And again, I have witnessed unnecessary calls to the ambulance service literally because staff in these homes don't receive sufficient training and are calling for help, perhaps because they're panicking or not getting sufficient support. And I just wondered if you had any comment, not necessarily on you know, how good or how bad these homes are, but what the sort of work that you're trying to do with the homes to you know, maybe stop them ringing ambulances unnecessarily.
Yeah, I think there has been a lot of work over the years with care home colleagues, and it certainly is a lot better than it used to be, albeit that does still sometimes happen. There is a system in some care homes called, I think it's called Airedale, where they've got access to that. That's their phone a friend rather than call 999. They phone Airedale where they can speak to a clinician. So there are a number of homes that have that as well. I think one of the challenges that we find in care homes, and we're not closely involved, although we sometimes support, is the high turnover of staff, and therefore making sure that the staff receive the regular training. I think that's, but I know across, I think they're council led, but I may be wrong. I think there are care home teams who do just that, go into care homes to provide support and guidance. But it is difficult. I think one of those reasons being that there's quite a high turnover of staff in care homes. Oh, there's Jo. She may know better.
Yeah. Yeah, so most of the homes do have the Airedale model. Most of the homes across Portsmouth and South East Hampshire do have the Airedale model. But as Tracy says, the high turnover of staff means we have to sort of keep working with those homes to sort of re-educate them and train them. And we, both in Portsmouth and across South East Hampshire, have care home teams which work with PCNs and the community health trusts who go in and do that education and training, and the for the more complex patients, the anticipatory care planning as well, to again ensure that we're not calling 999 appropriately. So hopefully those initiatives have helped Tracy and the team over the years. But
it's absolutely significantly better than it used to be.
Yeah.
Thank you very much. Thank you, Chair.
Thank you. Councillor Briggs.
Hello, Tracy. I think all members of SCAS have an extremely stressful job, and a lot of the criticism you get isn't always your fault. So my question to you, when the new ED has been designed, and we heard earlier it should go ahead soon, in 2 years' time, do you think your problems will be solved, that you will be able to drive up there and within the 15 minutes unload your patient and be up again? I think that's a question we should be asking now, because you've got 2 horrible, probably, winters to go through. And I think your staff, I don't know how much abuse you suffer in the areas you cover, that must have an awful impact on them. So really the question is, do you think in 2 years' time life will be better for you all?
If only I had that crystal ball. I would like to think, and we have been part of the ED redesign programme, which is good as well, because the team are taking into account what we need as well, which is great. It's like I said earlier, it will be fantastic to have an ED, and there's an ED, and there's lots of design positives going in that will support reducing the queuing. It still remains a system challenge in terms of making sure that we can flow patients through the hospital and out. So it's not just an ED issue, but I think the new ED, in terms of its design and flow through the department, will be significantly better than the position we've currently got. And if I may just come on to your next point, sadly, yes, our crews do get a lot of abuse and verbal and physical assault, sadly. We have now, in the last few months, introduced body-worn cameras, which I think folk will be familiar with. The police have had them for a long time. But the ambulance crews now have access to body-worn cameras, and that's about protecting them, and that's about making sure actually they do act as a deterrent. Even just wearing one sometimes makes people think twice about what they're going to do. So deterrent is the most important thing. But when things do happen, it means that we've got some evidence to then be able to support the crews through a court process, and hopefully a good outcome in terms of the bad people getting what's coming to them with some good evidence. So we are working on that as well, but it is an ongoing challenge.
Thank you. And I just think it's absolutely disgusting that people want to do anything against you who are trying to help them. Are you ever allowed to restrain them, or do you have to call the police directly?
We don't restrain. No,
you're not allowed to.
Not trained to do that. It's a bit of a not somewhere we want to go, to be perfectly honest. And we do get good support from the police as and when we need to. So
that's good. Thank you.
Thank you. Any other questions? Thank you. I think we all sort of recognise the pressures the ambulance service has been under. So just like to say thank you to you and your team at SCAS for everything you've done and are doing. Thank you.
Thank you. Thank you all.
Thanks. Last item on the agenda is Portsmouth Clinical Commissioning Group update. Joe, welcome.
Hello. Thank you. Thank you. Hopefully you've all had an opportunity to read the report. Not much to, well, a few bits I just wanted to update you on. Obviously, we have been quite busy in the CCG making sure that all the processes and plans are in place to safely transfer our staff and responsibilities into the ICB for next week. We've been doing all the due diligence checklists around that and all of the TUPE processes, so feel confident that everything is as well placed as it can be to enable that transition to the new organisation. There'll be formal sign off from the CCG board next Wednesday, but lots of the work has been done and signed off by the audit committee and various other committees within the CCG, and we've been doing that very much in partnership with Hampshire, Southampton and Isle of Wight CCG, and so it's really just a final ratification and any outstanding pieces of information, which there are very, very few, that will go across into the Integrated Care Board. So that's obviously been, important to us to make sure we get right, and that for the staff, all of that works and everybody gets paid on time and it all happens nicely and as smoothly as possible. And then we will look and work across with the ICB as to how things will look moving forward. Although for the immediate and for the most part, most of our staff will continue to maintain a place-based focus, Portsmouth being the place, but could equally continue to work across Portsmouth and South East Hampshire or across the wider ICB, which is how we've worked for a number of years really in Hampshire and the Isle of Wight. Locally, the other thing that has been really important to us is that we continue to maintain that place-based focus and the opportunity and have the right mechanisms for delegation from the Integrated Care Board into Portsmouth, and that we have the mechanisms to do that, and that will be through a health and care partnership board, which works really well for us because we've always operated for the last sort of 8 years under the auspices of Health and Care Portsmouth, so that will continue. And whereas we have a Health and Care Portsmouth Joint Commissioning Board, that will change a name to become the Health and Care Portsmouth Partnership Board, place-based partnership board, but the functions will remain. And we've been doing quite a big piece of work with City Council over the last 6 months or so, just to refresh our Section 75 arrangements that we have between us, because some of those have been in place for quite some time. And we have also been looking at how we can further strengthen that integration, and real commitment from the City Council to look at how we can focus on the wider determinants of health, and real enthusiasm for that across the ICB, and obviously the Portsmouth CCG board. But we're just making sure we go through a process, a due diligence process that's sort of started now and post transfer to make sure that those additional NHS budgets that we may want to include in Section 75s locally don't have any unintended consequences for anywhere else across Hampshire and the Isle of Wight. And so we're doing some mapping work with other places. And again, making sure that our ambitions are aligned, even though we may be further ahead than in some places with the scale of integration that we've had between the NHS and the council in the city. So really looking to maintain and to drive our ambitions further forward as we move into this new arrangement in line with the aims of the ICB and the integration white paper that was released in February. So it feels like we're really well placed for all of that, if I'm honest, to continue to develop and to work with partners on that as well across Hampshire and the Isle of Wight. So that's sort of has been a key focus for us over the last few months, as I've said. The other area that I just wanted to focus on from the report was around primary care, and I know there's been some questions raised earlier around that, and that there's been quite a lot of media interest in primary care, particularly in the city over the last few weeks, both in the news and on the news on the BBC. So just wanted to clarify around the numbers of GPs in the city and the fact that that's quite a low number. That's not necessarily a new thing. That number has always been there. We've always been on the lower side. But if you look nationally, you'll see that we're fairly similar to most other coastal cities across the country. What's perhaps different with this report is that where we've seen areas come together in CCG mergers, it's harder to see perhaps some of those other areas, but we know that there are significant challenges in Southampton, for instance, that are very similar to what we face in the city. So just wanted to put some of that context around it. As I say, this has been an issue for us for quite some time. We have, as a CCG, done a lot of work around how we can continue to stabilise primary care in the city through practice mergers to create that resilience. That's why we've gone from, I think, 28 GP practices in the city 7 or 8 years ago to 11. But actually the number of sites has been relatively stable. I know we've seen some changes in that provision more recently, but actually the number of sites have continued, so that access continued. We've also had a strong push on creating additional roles in the city, both under the new government initiative, with an additional 78 sort of other healthcare staff coming in. The integrated primary care service has again helped strengthen the primary care resilience in the city through acute visiting service, through the enhanced clinical assessment service, and we've also done initiatives over the years like direct access to physio, which all practices have. So patients don't need to wait and see a GP to be referred to a physio. They can get access straight through a physiotherapist. Having said that, we know there are some significant challenges now that have exacerbated our position. It felt like we were in quite a strong position in relation to GP recruitment and primary care resilience going into the pandemic. I think the pandemic for us, as long as other areas, we have really seen some challenges with that. Those challenges were there probably before, but I think the pandemic and the impact that has had on primary care alongside other NHS services has been seen. So we're really looking at how can we increase recruitment into the city, working across Hampshire and Isle of Wight, but also with our integrated comms team in the city, working with the public around the wider primary care team, looking at, we've just approved some funding to support PCNs, to support that development, so they have the capacity to think about how they might transform and work differently. We've been doing some work around locum rates, and also in discussions with Portsmouth Primary Care Alliance around how could they attract and recruit GPs into the city, not as a locum, but perhaps as a more portfolio option for GPs at different stages of their career, with some education, particularly for the newer GPs, or specialists for some of the more mature GPs, and how they can then work with practices. So we're exploring those sorts of options as well to increase GP recruitment. So we're also doing some work with practices around demand and capacity, so how they better match capacity to the demand that they're seeing across the day. So they're just some examples I wanted to kind of highlight, because I appreciate there are likely to be lots of questions around primary care given the media, and just to provide some assurance around some of the work that we are doing to support our practices in the city. And again, obviously I speak mainly for the city, but there are similar challenges and similar initiatives in South East Hampshire and right across Hampshire and the Isle of Wight. We're also meeting, so myself and our GP, some of our GP leaders are meeting with the leader of the City Council, Councillor Winnington as the Health and Social Care portfolio holder, and Susie Hilton, the Children's portfolio holder, and the Director of Public Health for the city, to again look as if there's more we can do in partnership to support and make Portsmouth seem a more attractive place to come and work, and look at how we can offer solutions differently so that patients, or the residents in the city, are getting the right service. And that might be through pharmacy, it might be through other members of the team, and really just sort of explaining that different roles that other members of the primary care team can have, that it's not all just about GPs. So I'll stop there because I expect there's lots of questions. But
thank you, Jo. Councillor Agate, I think you got your hand up.
Thank you, Chair. Jo, page 68, Portsdown practice. Practice committed to reduce e-consult time down to 3 working days within 3 months. Do you know if they've achieved this? You're on mute.
Apologies. Yes, they are very, very close to that. They do have they have submitted a report to us, and yes, I think it came in slightly later than perhaps the report had to go, but yes, they're very close to and have achieved that. So that is a real significant improvement as per the discussions that we had with them.
I have friends who will really appreciate that. Thank you.
Thank you.
Thank you. Councillor Richardson.
I have got my microphone on this time. Thank you, Jo. Very interesting discussion. In terms of recruitment, not just for GPs, but particularly for nurses, I mean, I'm still on an emergency register in terms of COVID responses, and I'm 68 years old. I don't think I would be much use in a hospital. I might be in primary care. However, some of the issues around recruitment are really around about the way the government has changed the way they train nurses. And I wondered whether or not you're sort of feeding into that, with the universities and obviously with government departments. Certainly, it's a long time since I trained, but when we went into hospitals and we were paid as as we went along and trained, that was much more helpful, even though it was a very low wage. But now nurses are not so happy about going in and having to fund all their training and then pay it back out of a relatively small wage by comparison. And I'm sure this is also an issue for OTs and physios. And I don't really know so much about doctors, but I just wondered how much you are working or sort of contributing towards those sorts of issues.
Yeah, can you bear with me 2 seconds? I'm just going to shut the door because I've got some drilling in the background. Apologies for that. I think some of those challenges are national, nationally driven. we continue to work, not myself personally, but through our workforce leads across Hampshire and the Isle of Wight and the universities to look at how we can make some of those changes. There are more things coming in now, like apprenticeships that we can use and graduate apprenticeships. So they will definitely help. A lot of our NHS providers will run bursary schemes as well. So they will take perhaps people who are on perhaps a healthcare assistant and provide bursaries and support them that way. So they don't have the costs perhaps of or come out with the university loans, etc. So there are different ways of doing it, and we continue to look all the time. And I know Solent NHS Trust has talked to you previously around their plans for all the work they've done, successful recruitment they've done from international students as well, so and international nurses. So we look all the time at how we can improve, be innovative, change the way we work to accommodate and support people into the NHS, and particularly the nursing profession. And again, those, you know, continuing to work nationally as well with NHS employers, etc., to really think through how can we support that differently. Yes, and open it up to more diversity.
In terms of international recruitment, I mean, I've been involved in that in the past and quite successfully.
Yeah.
However, you know, we can't keep going to other countries. We're denuding other countries of their good nurses, and you know, there are also problems with international recruitment. Certainly, some of the experiences I've had, you know, where patients can't necessarily understand. So, you know, there are issues with international recruitment. So again, I don't think that is really a solution to the problems that we have. But I understand that the drive to it.
Yeah, it's one of a number of short-term improvements and things you can do locally whilst we work at a national level to make changes. I think the other change that will help is around some of the apprenticeships, and NHS employers have reduced the sort of automatic requirement for somebody to be entered into level 2, so GCSE maths and English. They don't have to do that now. They're looking at ways they can do that differently. So again, that creates a different route in for people that is perhaps a more practical focused route in the future and supports them. So lots of different ways we can manage that. But yeah, you're right, that there are national issues around recruitment that we have to national constraints that we have to work within.
Yes, okay. And sorry, just one last question. I mean, I find eConsult is fabulous, but I'm a nurse, I'm an ex-professional, so you know, I understand how that works and I know how to use that system. I'm a real advocate of telehealth services per se. So 2 questions really. Are we expanding or using telehealth services much more in a useful way? And in terms of eConsult, how are we managing those symptoms to help people use those more efficiently and proficiently?
Yeah, so definitely in terms of telehealth, I think we have some really good examples of where that works well, but there's definitely more that we can do. And certainly as we move into the Hampshire and Isle of Wight ICB space, the opportunity to do more of that at scale will benefit all of us. But again, I think that there's a long way for all of us to go in relation to that, and to work with our primary care providers who are all independent contractors as well. With eConsult, again, we've got lots of learning and lots of work with practices around how they manage it and how they can manage it most effectively, and what then advice they can produce, support their patients with. And again, how we can work with the supplier to make sure that system it works all the time. You hear some odd anomalies. Most of the time it works really well, but then you'll hear the odd anomaly of somebody who's used in an eConsult inappropriately, perhaps late in the evening, and then there's a panic when someone spots that in the morning, So we've addressed some of those issues, or equally somebody with a very minor thing that's absolutely appropriate for e-consult somehow gets flagged as more of a risk than it actually is. So we're continually working with practices around their processes and with the e-consult provider around how we make that as good as and a robust a system as possible.
Thank you, Jo.
Thank you. Councillor Agate.
Thank you, Chair. Joe, what about retention? How are you getting on with that?
In terms of GP retention, I think that's quite good. I think if we can get them into the city, they do tend to stay. We have quite a stable and quite a close-knit primary care community, actually. So that is less of an issue. I think it's how we get those new GPs in and create the opportunity, the sort of locum plus or the salaried or the partnership opportunities for people to come into the city. That's probably our biggest challenge. I think, if we can get them here, then we can show them what a great place it is to be and place to work.
You've not done too well with dentists.
Now dentist is another thing altogether. Dentistry, as you know, is currently commissioned by NHS England. That will change within the ICB. Delegated responsibility will come to the Integrated Care Board.
I understand.
And we are learning. Learning
I understand
fast.
you've got somebody appointed to take charge of this.
So I'm still looking to recruit a local post that will work with us to support NHS England, and our priority areas are Portsmouth, South East Hampshire, so particularly Havant and Gosport and the Isle of Wight, closely followed by Southampton. We had a dental summit recently organised by Penny Mordaunt. That was really, really useful, really productive, really open conversation, and explored some of the challenges and perverse incentives that are within that system around how we attract dentists into the NHS, and again some really, really significant national issues around the national contract, around registration, around how long it takes, how long you have to be an NHS dentist for before 4 years before you can mentor another NHS dentist. So there's some real challenges nationally that we got some commitment to address with the people in the room. So the MPs and the GDC, the General Dental Committee, and Health Education England to really look at some of those challenges as well as some of the providers. There's also some more probably we can do locally. There's a Hampshire and Isle of Wight dental network. So we can, under the ICB, start to look at more specific commissioning that is more focused around needs. So we are looking at that, and I've also not really sure why, but have put my hat in the ring to lead on dentistry until we get somebody in on a permanent position across Hampshire and the Isle of Wight, so to pick up some of those issues, primarily because it is such a big issue for us here in Portsmouth, so that makes sense. But closely followed around this Portsmouth South East Hampshire patch. So yeah, next time, Councillor Agate, you probably will be able to grill me about dentistry a bit more, and I will hopefully be able to have some more detail for you.
Could you include Clanfield within that? I've got 2 elderly next door neighbours, neither of whom can get an NHS dentist, both living on their old age pension. So private dentistry is a little bit beyond their means. The teeth are not actually dropping out. Well, they might be. I'll have to go and check on my next door neighbour's teeth later on. But it's one of the bones of contention within this area that we have one dentist and no NHS. I mean, I'm lucky. My dentist is in Southsea from way long back time ago, so I still get treated by the NHS. Yeah. But I shall explain your position to him or to them and see what they say.
Yeah, I think there are no easy fixes, but I think there is a lot of commitment, particularly from our local MPs who are all represented, and NHS England, who are in negotiations with the dentists to resolve some of the contractual issues that are, you know, national issues. I don't think there are any necessarily really easy quick fixes, but we will certainly be able to give you more information perhaps around what some of the challenges are and what we can do locally to support dentists in a more practical way post that changeover. You know, which NHS England are really supportive of. It's just been more challenging for them to do it, and you know, we'll be able to work more flexibly and more better able to meet local needs, I think, under the ICB. But the national contract change is going to be really important too.
So, judging by your recent comments, would there be any chance of some improvement if we spoke to our MP?
I think the MPs are all on it. They're all very concerned about the issues locally, and are working with the minister to try and support how those national policy changes are enacted and speed them up through the processes. We're waiting for the outputs from the summit that we had locally, and then I suspect some of that will be shared, and the actions that all partners committed to try and sort of improve the position both locally and at that national level.
It was just a lovely opportunity really to slope my shoulders onto her rather than the amount of times her little problems end up on my computer. But thank you very much.
Thank you. Are there any other questions? No, I think then that's the end of this meeting. If I could just ask everyone to keep their microphones switched off until the live feed is switched off. Thank you, Jo.
Thank you.